Good morning, everyone. We're going to talk about artificial intelligence and focus on image reconstruction. We're going to do a little bit of preamble, or actually a decent amount of preamble for this first talk, talking about the hype and reality of AI, the strengths and limitations, and some of the benefits and controversies that are going on. But we're really going to spend most of our time warming you up, getting you ready to look at where we are with AI and image reconstruction, which is one of the most impactful changes that we have in medical imaging. So at this point, we all kind of know what AI is. It's a science that lets computers do things that emulate human behavior. It has a wide variety of forms. You can see that it is something that is getting a ton of investment over the years. The federal budget is up to the area of $1.84 billion just invested in AI, and corporate investment in AI is also very, very impressive and increasing as we go along. So this is a very, very important technology. You can see from a recent McKinsey report, while in 2017 only 1 in 5 companies used AI, by 2022 half of the companies used AI. And the reality is there's probably even more. There's just AI in the products that they use that enhance them that doesn't even show up. 63% of all businesses are going to increase investment in AI. So it's a big deal. The World Economic Forum 2022, 1 in 4 companies say AI is responsible for a significant piece of their net earnings. And 70% of companies reported an AI-powered revenue boost. So it's a big deal. Now in healthcare, you can see the big technologies in healthcare between big data analytics, a classic machine learning, a deep learning application, as well as what they're calling traditional AI. It's a very, very big deal. And we're seeing this investment in healthcare all around, and we'll cover some of that. At this point, we know that AI is all around us. It's following us. It's when I open Uber, when I get to Las Vegas, it actually knew I wanted to go to the Aria Hotel. I don't know how that is, and I don't want to ask, but it's there. It's responsible for things like autonomous driving, beating experts at games like chess and Go. It's what makes the what fuels the online advertising that gives me the ads for Snake River Farms meats every time I open my browser. It's been referred to as the new electricity. Now, the term artificial intelligence was coined in the late 1950s, but we really didn't hear much about this in day-to-day life until the advent of neural networks back in 2012. And these are mathematical systems that essentially can learn skills by finding statistical patterns in enormous amounts of data. As a matter of fact, if you show it 1 million cat photos, it starts to recognize cat photos really, really well. As a matter of fact, where we are today, computers are better than humans at image recognition. And computers are better than humans at speech recognition. So it's really pretty impressive stuff where we are today.
Okay, so yes, this talk is on dementia imaging. And we will look at the causes of dementia, imaging of dementia, potential emerging treatments, and ARIA, which stands for amyloid-related imaging abnormalities. So there's a lot of different kinds of dementia or causes for dementia, but some of the big ones would be Alzheimer's disease, vascular dementia, dementia with Lewy bodies, frontotemporal dementia, logopenic progressive aphasia, traumatic brain injury, cerebral amyloid angiopathy, CAA-related inflammation, and normal pressure hydrocephalus. So when a patient presents with memory loss, usually cognitive testing is done, and the referrer will often order an MRI, in part to really exclude some other structural cause for the memory loss. At this point, we encourage quantitative volumetric imaging, and then if there remains clinical ambiguity, sometimes a PET is done, typically FDG because that's reimbursable, but sometimes also amyloid and tau. This is a positive FDG where we see cortical hypometabolism in the temporal lobes here. This is the PET-MR fusion, PET-CT fusion, and another PET-CT fusion image. Just for reference, this is what a negative amyloid PET looks like, as sort of a tree and branch pattern where the cortex is light but the white matter is dark. And this is a positive amyloid PET, diffuse binding of the tracer throughout the cortex. Now, quantitative volumetric imaging will identify and label anatomic structures and then quantify the volumes of those structures. So this AI tool is very good for assessing atrophy in patients with dementia and the patterns of atrophy. It then compares that to a large age and gender matched normative database and provides volumetric tracking over time. Now, there are a lot of different quant companies on the market space. This is what the segmentation looks like with NeuroQuant. This is IcoBrain, Quantib, and Combinostics. This is Darmian, a product in development here. And they all have different reports. This happens to be neuroquant, and you see here pertinent structures that might be related to dementia. The quant can be used in multiple other things as well, which we'll talk about in a different lecture. But the hippocampus, the entorhinal cortex, and the lobar cortices. Anything in the pink here is more than 2 standard deviations outside of the mean. And this is the triage brain atrophy report. Again, more structures listed here, and the red boxes are statistically significant, 2 standard deviations outside of the mean. This is IcoBrain's report. It's slightly different company, but again, the pertinent structures, anything in the blue is at the 1 percentile, and this is sort of a spider graph that points to different lobes in the brain. This is a Combinostics report. It actually predicts what kind of dementia pattern you might have. Here it's predicting off of the MRI that this patient might have Alzheimer's. Now here's a look at some different PETs, amyloid PET, tau PET, and FDG. Normal on the top here. So with amyloid PET, we get that diffuse pattern of binding throughout the cortex. Tau would be, for example, like an Alzheimer's patient, would be temporal lobes, parietal lobes, posterior cingulate gyrus. And FDG PET would have a similar sort of pattern as the tau, again, for example, for Alzheimer's, parietal, temporal, and posterior cingulate gyri. Here's some FDD PETs and different patterns in different diseases. Here's Alzheimer's, which we just talked about. FTD would be really more frontal lobes, temporal lobes, anterior cingulate gyri. And dementia with Lewy bodies will often look like an Alzheimer's pattern, but also involve the occipital lobes.
All right. Some of the cases will actually dovetail nicely with work that was presented by Dr. Ross earlier. So we're going to be looking at several entities, delayed post-traumatic cervical instability, and our role in detecting the presence of that on that first scan. Talk a little bit about Bertolotti's and Bastrop's disease, which some of us may not be very familiar with. Thoracic myelopathy and anterior cord herniation. You saw a beautiful example from Dr. Ross. I'll show you some, as well as intraoperative correlation. And then acute postoperative cervical myelopathy and the role that we can play as interventional physicians and diagnostic radiologists in suggesting the presence of the entity. And then in postural headaches and intracranial hypotension or hypovolemia, as Dr. Ross mentioned, with particular focus on interventional percutaneous approaches that we have taken to some of these challenging cases. So here's an individual, a 40-year-old woman with polytrauma, non-contrast MR of the cervical spine. At first glance, things look not so bad. We can see that there may be a little bit of anterolisthesis at this level, C6 on C7, minimal prevertebral soft tissue swelling. As we look at the T2, it looks like there may be some abnormal signal in the anterior and posterior annular margins, an increased T2 signal in the paraspinal muscles posteriorly that would indicate paraspinal muscle edema. But if we take one more sweep through the scan, we can see that there appears to be a disruption of the anterior longitudinal ligament here at the level of the annulus fibrosus, and the posterior longitudinal ligament as well appears to be disrupted, discontinuous. You can see the discontinuity here in the sagittal T2. The prevertebral soft tissue swelling certainly raises concern for injury to the anterior longitudinal ligament, and then avulsion of the anterior aspect of the annulus in conjunction with potential injury to the anterior and posterior longitudinal ligaments now puts you potentially into an unstable situation because you've disrupted the anterior longitudinal ligamentous complex. But when you add to that the fact that you see so much extensive posterior paraspinal muscle edema and also edema in the interspinous ligament area, now you have to be suspicious that you've disrupted the entire anterior and posterior longitudinal ligament complex because the interspinous ligament in conjunction with the supraspinous ligament and the pericapsular ligaments of the facet joint really define that posterior ligamentous complex and help to stabilize the spine posteriorly. So now potentially we've set up a situation where we've disrupted the anterior and the posterior longitudinal complex. So in a case like this, we might not say with 100% certainty that we have these pathologic entities there with the ligamentous disruption, but we would certainly raise the possibility because you don't expect a 40-year-old woman to have degenerative anterolisthesis. right? And if they're scanned hyperacutely, like many patients are now, they're taken straight off the freeway and right to the emergency room, we may be getting these patients within a couple of hours, or sometimes even less, from the time that the injury occurred. So there won't be that much prevertebral soft tissue swelling to draw our attention to that level. So even this amount of prevertebral soft tissue swelling should raise our concern. And then, of course, visualization of the high T2 signal within the annular region should raise our suspicion that we're dealing not with a fracture through the vertebra, but literally a quote-unquote fracture through the disc. So this is a traumatic disc avulsion. And so in a case like this, you would say suggest delayed imaging, or potentially if the patient can do it themselves, after several days, they can do their own self-directed flexion extension radiograph. So the patient themselves determine the degree of flexion extension that they're comfortable managing. So it's not us manipulating their neck, they're doing it themselves.